Pleasure to be here with you all. Public health aspects of legalization are on tap for this afternoon. I'm very happy to try to relay three kind of key challenges that I see for really adopting a public health viewpoint on how legalization should go. One of the things to keep in mind as I get oriented here. Oops. I'll say we have no conflicts of interest to declare at the beginning. But one thing to keep in mind, I'm not sure why that's doing it. Oh yes, here we go. So what is a public health approach to cannabis? One of the things that's really critical to say at the front end of this is I think the illegal status currently of cannabis has really shaped a worldview around how we think about cannabis use, where any use is equivalent to misuse because of its illegal status. This has long-standing knockoff effects that really have created some problems for adopting a public health approach in this area. Public health approach really is designed to acknowledge that there is a continuum of substance use, including cannabis use, that includes beneficial as well as harmful effects. It takes into account the idea that control of substances have to acknowledge both the positive and negative consequences of control efforts, and to seek an optimal balance between harm and benefit at the population level. And so when we think about public health approach to cannabis, really we have to start thinking about in terms of the entire population of users of this substance. And like any substance use, this is a pyramid concept. At the base of the pyramid are healthy population. This includes non-users of cannabis as well as healthy users of cannabis, people who use cannabis with no ill effects, no social consequences, and so on. And in every drug that we study, this is the case that the size of the population at the base of this pyramid is always is larger than any other component of the population in general. A subset of people are at risk for developing problems related to cannabis, and a subset of those people go on to develop problems with cannabis. And at the very top of this pyramid are folks that actually meet clinical criteria for dependence on this drug. Very important to keep the size of these parts of the pyramid in mind, because we're talking about, just like alcohol, most people drink alcohol moderately with no problems. Same with cannabis. But there are subsets who exhibit increasing problems. And so when we think about this pyramid, we can think about problem severity increasing as we go up the pyramid, and this could be chronicity, complexity of problems, acuity. And when we think about services that we provide for people, the intensity of services that we provide as we go through the top of the pyramid increases in intensity. So it's much more intense experience to treat someone with cannabis dependence than it would be to intervene with an at-risk user in a school context, for example. Service extensity, it's a fancy word to say that as you go up the pyramid, there's fewer and fewer and fewer people affected. And so as you go down the pyramid in interventions to minimize harm from cannabis, you reach more and more of the target population. So very important public health concept, foundational to keep in mind. It costs a lot more to treat people at the top than it does to intervene with people at the bottom of this pyramid. Okay, and that plays into our thinking about how we allocate priorities and resources. So, having set that stage in the context, let me go through some of the most current epidemiology, the current numbers on cannabis use. These are the overall numbers. We're talking about 34% of the Canadian population aged 15 years of age or greater. This is the most recent Stats Canada data. Have used in their lifetimes. Past year use, 12 million people, 12%, 3.6 million people, slight increase from the previous survey date. Prevalence is higher always, and with most substances of abuse, higher among men than women, And there's a range of cannabis use prevalence across the country, and you can see Alberta highlighted in the red there, slightly below the Canadian average in both terms of lifetime and past year cannabis use. But we're still talking about 11.1% of a whole lot of people. That's a lot of people. And again, the pyramid applies. Past year use doesn't necessarily tell us about problem use or dependence. Here's the breakdown in terms of distinctions between ever, past year, past month, and daily use. And again, males are higher users at all of these different use levels compared to females. We're still at daily levels. We're talking about 4.3% of males, 4.3% of Canadian males, and 1.5% of Canadian females reporting daily use of cannabis. Here's, if you break that down by age grouping, of course you find that ever use is the highest, and you find that there are reliable decreases as a function of increasing involvement with cannabis as a function of age. These data are for Canadian youth, a very large sample of over 30,000 kids. And again, this would be kids from grades 7 to 12, Canadian numbers in aggregate. And again, same graded pattern for many more ever using and progressively fewer using over last year, last month, and then daily. But still, we're talking about 1.5% to 2% of kids in grades 7 to 12 reporting daily use. This is a breakdown by age, very reliable age-related trajectories that we're talking about. So, of course, as kids in the younger grades report lower involvement, but as kids get older, they report increasing involvement across to grade 12. And here are the Canada versus Alberta comparisons for youth. Currently, most current data, this about 6,000 kids sampled in Alberta. Our group does the field work for this Health Canada project. Consistently lower than the Canadian average at present. Now, I've just presented data on cannabis, but it's really important that you keep in mind, we're talking at a cannabis meeting, but polydrug use and multiple substance use is the norm. And so how does cannabis use relate to other drugs of use? Of course, alcohol, still the heavyweight champion in the room, and these are past year substance use reported across Canada. Interestingly enough, sort of a secular trend down for all substances, including cannabis, from 2008 to the most current data, 2014 to 2015. But very important to know, cannabis relative to other drugs, we're talking alcohol still is the heavyweight champion in the room, and it calls into question just to what extent should we be focusing on cannabis only when we think about a public health approach. The big public health challenge around these prevalence estimates and the numbers in the epidemiology is that the epidemiologists, sorry, epi people in the room, the epidemiology is very rarely made meaningful. It's often used to determine risk factors and so on, but very rarely used to plan services, to plan for size of needed to treat populations, whether we're talking interventions for prevention or more structured interventions for dependence. Most notably, these national and provincial estimates of use do not take into account problem severity in any meaningful way. So, yeah, I can show you the curves for past cannabis use in the past year. I can't tell you what percentage of those kids exhibit problems, what percent are at risk, what percent meet clinical criteria for dependence, because the epidemiology, the surveillance efforts around this simply aren't sophisticated enough. An artifact of the fact that we've treated cannabis as any use is bad. We need to be more sophisticated, and we really need to broaden our focus on surveillance to link it to prevention and to treatment interventions by assessing problem severity in a systematic, routine way. Now, having said that about the numbers, regulatory frameworks. Why legalization and not decriminalization? Here's the Canadian Centre on Substance Abuse's sort of continuum of regulatory approaches. On the very left, the most harsh, illegal regime, China, and then all the way over to the right, out-and-out commercialization and legalization. And there is a variety of options. One of the things that we can tell you from public health is that either end of this continuum leads to maximum levels of harm at the population level. Unregulated illicit markets and unregulated free markets both promote the maximum amount of harm. And so the most public health discussions around this really focus on a sweet spot, strict regulation combined with legalization, and indeed that's the model that the federal government has proposed. Main underlying rationale for legalization: in our current illegal regime, we have the highest rates of cannabis use for youth in the world. We have consequences for Canadians of all ages with criminal records associated with possession and so on. Profits are going to organized crime, and vast majority of Canadians support legalization. How about the federal task force? Just a quick tour through some of the main things that they focus on. They're really focusing on a big push for protecting children and youth. I think that is partly political, partly substantive. They want to divert profits away for organized crime, reduce burden on justice, increases in public health and safety. Driving and motor vehicle operation, a big issue that will not go away. And has to be addressed adequately. They endorse a broad, well-informed public through campaigns, strict production distribution system with a lot of regulations around quality, safety, access, and so on. And there's been some suggestions about ongoing data collection and research, although these really have not been articulated to date. Some of where the rubber hits the road, they're recommending a national minimum age purchase of 18, plain packaging, developing factual public education campaigns, focusing on vulnerable and populations and youth. All very good. This is the Center for Addiction and Mental Health and their recommendation of an appropriate regulatory framework for cannabis. These are the elements that we know from other areas in public health that make a difference in terms of reducing the overall population harm of substances. And you can see some of the elements here. They recommend a government monopoly on sales, minimum age, limits on availability, pricing considerations that curb demand, prohibiting marketing and sponsorship, taking this out of the commercial realm, product information for consumers being prominently displayed, investments in education, research, treatment, and so on. And these are all really well-worn themes in public health. We know from tobacco control and other areas that if you, jurisdictions that implement these sorts of regulatory frameworks achieve the maximum sort of benefit for population health around legal substances. So the second challenge, though, that we have around this is that if we all agree that regulatory regimes like these make a difference, one of the things that we're going to struggle with in Alberta and in Canada is really ensuring that there is protected funding to implement these regulatory regimes. And so it's instructive to think about what Alberta is currently spending. And there's several points to make on this. If you look first at the percentage that mental health and addictions as a sector accounts for of the whole healthcare budget in our province, it's just around 4 or 5%, depends on the year. 4 to 5% of all the healthcare spending in the province goes to addiction and mental health, yet population data from many jurisdictions around the world indicating that addiction and mental health problems account for about 25% of the total disease burden. So we have a massive imbalance in spending in the health sector to prioritize mental health and addictions. And then when you take a good look at where the addiction and mental health money is currently being spent, it's about 80 to 20 mental health favored over addiction. So it raises the question, how are we going to do this effectively to ensure that regulatory support for legalization can be done in an effective way? Here's something to keep in mind as you're pondering that. This is revenue from the Alberta government last fiscal year. And here's the legal addictive behaviors and how much money goes into the provincial government for alcohol, gambling, and tobacco. You total it up, it's over $3 billion in a fiscal year. Now take a look at the comparable entry for total government revenue for all non-renewable energy. Less than $3 billion a year. Yeah, we had a bad oil year, of course. It's less. It sometimes is higher than that. But the point is, everything we talk about in this province is about oil prices and oil revenue and so on, and how much are we getting and so on and so forth. But take a look at how much we're putting into provincial coffers as a function of the legal addictive behaviors without cannabis legalization. Keep that in mind. It's important. Advocate for it. So one of the challenges, I say, ensuring protected funding is available for implementing regulatory regimes. Here's the way that we do it in Alberta and Canada. We get money out of tobacco, gambling, alcohol, soon to be cannabis. It goes into the general provincial pot. After that happens, some mysterious political process happens, and then funding is announced for various initiatives. It's kind of like it's a black box. Who knows? Here's how the states is approaching it. Money comes in. The state legislatures mandate priorities for cannabis revenue to fund initiatives before it gets to the general revenue. Shocking. But that's the way it's being done. And here's some examples of where these legislative priorities go in the case of 3 American states. And you can see, prior to getting to general revenue, you can see the priorities that states that have or will soon legalize cannabis on the official state policy frameworks. What they're proposing has to happen before it gets to general revenue. We need to make a case like this to ensure regulatory support for legal cannabis. Last point, general point I want to make is about intervention strategies and system-wide planning. This is a third challenge for public health. Let's imagine that we did solve the revenue problem. We had a robust regulatory framework in place. Unfortunately, our system of treatment and prevention interventions for cannabis intervention really is not currently up to the task. And here's what I mean by this. If you go to the base of the pyramid, what are we doing for the general population? Well, we're using ineffective universal prevention activities like the DARE program, which has been a staple in this province for a long time. What are we doing when we look at-risk populations and users who might meet clinical criteria for problematic cannabis use? Well, there's exceptionally low rates of case finding if you go to your family physician. The rates of case finding for alcohol misuse, the one that was described this morning as one that it's taught in medical school, it's atrocious. It's 10, 20% at best of physicians asking about alcohol in a routine consultation. So case finding is exceptionally low. What about if you actually manage to get into the system and you get picked up? Poor continuity of care between primary, acute, and specialty care. Handoffs between your family physician and the specialty addiction treatment system, atrocious. Long waiting lists for accessing specialty care and so forth. And throughout this system, underuse of evidence-based intervention approaches. Future state should evolve if a public health approach is adopted to a step care model where we, at the base of this, adopt universal prevention activities that consist of factual information, non-judgmental information, lower risk guidelines for cannabis use. There's a large and growing Canadian body of evidence around the utility of personality-matched interventions for at-risk kids that teach them coping skills that transfer from cannabis to other areas. We don't use those. Routine screening and brief intervention provided in a variety of contexts, including physicians' offices, greater treatment capacity, and so forth. And last, as one of the sponsors of the event, just give you a little bit of material on CRISM, the Canadian Research Initiative on Substance Misuse. Really, this is a national network set up by Canadian Institutes of Health Research to help identify appropriate evidence-based interventions for prevention and treatment of substance misuse. And it consists of a national network and 4 hubs around the country, over 500 members affiliated with this. We're doing work on opioid treatment, a national guideline around that, doing work comparing methadone and Suboxone in treatment programs, working on national lower risk cannabis use guidelines. And here's an example of a project that we're doing in the Prairie region. This is an example. We're working on some web-based resources that we think could be helpful for public health purposes for people that would be interested in cannabis, including service providers, parents, and youth and young adults, educational, non-judgmental, factual information and lower risk use guidelines, screening and brief intervention materials made available online, and then appropriate referrals to other sorts of resources. We urgently need this kind of connectedness in the information that we provide to make a difference in this area. Thank you so much for your attention.